Well, welcome to this webinar on difficult to control diabetes. Consider hypercortisolism. My name's Stephen Brunton. I'm a family physician in rural South Carolina, and I'm executive director of the private care Metabolic group.
Hello, and I'm Ashlyn Smith. I'm an adult endocrine PA and the immediate past president of the American Society of Endocrine PAs. I'm happy to be talking to everybody about this topic today. This topic is presented with sponsorship and support from the Primary Care Education Consortium and supported by an educational grant from Corcept Therapeutics. And working in collaboration with the Primary Care Metabolic group, this is a great group, a large group of primarily primary care clinicians who are interested in metabolic disorders. You can take a look at the website below, join for free, and you get free CME discounts on conferences and some great resources if you're interested in metabolic disorders. Here's our very important CME and CE information. The accreditation for this program is in support of improving patient care. Primary Care Education Consortium is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, the American Nurses Credentialing Center, and the American Academy of PAs to provide continuing education for the healthcare team. We know that healthcare is a team sport. And this credit designation for this activity was planned by and for the healthcare team, and the learners will receive 1.0 interprofessional continuing education credit for learning and change. And according to your request, at the end of this program, you will receive either ACCME, ANCC, or AAPA certification, and all other clinicians will receive a certificate of participation. And there's an extra opportunity for more credit. If you want translation to practice credit, you may qualify for an additional 2.0 credits if you make a commitment to change your practice behaviors in your post-presentation survey. During that survey, you'll be asked to do a couple of things: to commit to changes in your practice behaviors, and you'll want to specify what those changes are, and then provide your contact information, your name, and your email address for follow-up. If you don't enter that data mentioned above, you won't be qualifying for the translation to practice credit, so be sure to fill out that information. And then about 6 weeks later, we'll reach out to you asking if those changes were made and a couple extra questions. And if you have completed those changes, you'll be eligible to complete the survey and generate a certificate for the additional credits. Here's our faculty disclosure information. Primary Care Education Consortium works very hard on a strong conflict of interest policy to make sure that our programs are evidence-based and bringing you the most relevant evidence-based medical education. So we work hard to make sure that any conflicts of interest are mitigated for this program. For the disclosures for your faculty, and participants in this presentation, by the end of the program, you should be able to screen patients presenting with multisystemic heterogeneous manifestations of hypercortisolism for the disease. You should be able to integrate evidence-based strategies for selecting appropriate patients and screening methods for identifying hypercortisolism into clinical practice. And finally, implement methods for working with the entire healthcare team, including initiating effective referrals to endocrinology for patients with evidence of hypercortisolism. And with that, I'll hand it over to you, Dr. Brunton.
Well, thank you. This is such an important topic. It's something that we really haven't spoken very much about in clinical practice. And we'll talk a little later, Ashlyn, but I'm surprised how frequent a problem this is in our patients that have been hard to control. And I think the data that we've received and we'll talk about in this meeting have really sort of been a revelation in terms of many of the patients that I thought were a real challenge to manage. Now I think there's an understanding of why that might be and how we might address that. So let's talk about what hypercortisolism is. We've referred to it in the past as Cushing's syndrome, and certainly that is still an appropriate term. It really refers to prolonged excess cortisol activity that's not due to a normal physiological etiology. So it's excessive cortisol. That's pretty much what it is. But the way it manifests, we'll talk about how that is, but there's a whole family of disorders that elevate cortisol activity or disrupt the normal cortisol circadian cycle. And once again, this is we've really had much more knowledge about this in recent years because of the study, particularly the Catalyst study, which we'll refer to. So how do we classify hypercortisolism? Well, there's potentially into two main categories. One is ACTH dependent, and the other is ACTH independent hypercortisolism. So the ACTH dependent includes excessive adrenocorticotropic hormone secretion by pituitary tumors, and we call that Cushing's disease, or non-pituitary tumors such as ectopic ACTH secretion. More commonly now, I think we see autonomous cortisol secretion by one or both adrenal glands. So if we look historically where this comes from, back in the day, we used to have eponymous sort of a nomenclature. If you were smart enough to find out what's going on with the disease, you could name it after yourself. So basically, it was Cushing, Dr. Cushing, who came up, Harvey Cushing, with the index case of Cushing syndrome in the early 1900s. And so we used to consider it a very rare disease. It was the disease that had a pituitary source we traditionally thought of as the most common etiology, and that incidence is quite rare, nearly 8 cases per million per year. And so that was previously estimated to represent about 70% of Cushing syndrome cases. As you'll see, that was a vast underestimation, or actually overestimation of what we actually see in practice. So currently we know that it's more common than we thought, and that's because we've got better ways of imaging. The CT scanning and magnetic resonance imaging scanning showed us that there are incidental adrenal tumors in up to 50% of patients that receive routine abdominal imaging, for other reasons, and we see these incidentalomas. And the evidence of autonomous cortisol secretion in the absence of clinical features of overt Cushing syndrome has been found in up to 30% of patients. So historically, we assessed prevalence of hypercortisolism across the spectrum of severity, but that has limitations such as different definitions and methods that have limited their accuracy. So now, with better diagnostic tools, we can more accurately predict which patients have this. Now, as a primary care clinician, we manage most of diabetes, particularly the patients that have a difficult to control diabetes. And so as we try to focus on the clinically inapparent hypercortisolism, we can have a key role as primary care clinicians. Many patients are missed, or they have delayed diagnosis, or they may not have access to care by endocrinologists. We also can identify patients that are at risk for hypercortisolism and use very effective screening tools that aren't that difficult to use that can help us identify the disease. And also, importantly, we can work with the team. Particularly, we can initiate effective referrals to endocrinology as part of that team and using specific approaches. And we'll talk a little bit later, and Ashlyn's going to focus on the role of the healthcare team, but also recognize that we need to alert other members of the team, particularly endocrinologists, that may not be thinking about this disease either. So let's talk about a patient case scenario. Always good to put it in perspective. This is a 52-year-old man with type 2 diabetes, hypertension, obesity, and hypothyroidism, and he presents to his primary care clinician for a routine visit. Now, during the visit, the primary care clinician notes that his type 2 diabetes is becoming increasingly difficult to control due to rising blood glucose despite appropriate treatment escalation. So, Ashlyn, what raises your suspicion for the possibility of hypercortisolism in this patient?
Dr. Brunton, I think this is a case that we can all identify with. We've seen this day after day in our practice, and I think it can be really easy in a busy practice to just reach for that next medication, give the spiel about diet and exercise, and move on to the next case. But in this situation, we've got type 2 diabetes. We've got a few comorbidities that really start to raise that suspicion. We've got hypertension and obesity. And moreover, we're seeing that control worsening. We're seeing that it's progressing more than we might expect it to. So that's when we should pause and think, is there maybe something else going on? We've got multiple comorbidities that might be related to cortisol, and then we see that progression of the disease process as well. So that's when that spidey sense should be tingling, and maybe we should be thinking about hypercortisolism. And we'll talk here in a little bit about specifics that really would raise that suspicion, because and how important that pretest probability is in identifying these patients.
It's so important to even think about this. I know in many cases we kind of blame the patient and say, well, it's because you're not taking your medication. And certainly adherence is an issue with regards to poor control. But thinking physiologically, what else might occur? So let's think about what may be occurring physiologically, because this is a multi-systemic, heterogeneous presentation. And I don't want to overwhelm everybody, but I'm going to talk about all of the ways it can present. You mentioned some of them, but certainly there are a number of ways, because cortisol is a ubiquitous hormone that can affect multiple systems. So here we have, in terms of looking at some of the overt symptoms, and certainly that can help us clearly identify these index cases that were certainly identified by Dr. Cushing in 1912. And this is central obesity, wasting of extremities, easy bruising, purple striae, and rounded moon face. You see a patient like that, it's pretty easy to acknowledge this patient is fairly typical. But it's the non-specific features of hypercortisolism that should raise our index of suspicion, because many patients don't exhibit these classical overt symptoms. So you might have weight gain, which is fairly typical, obviously, in patients with type 2 diabetes, hypertension, hypokalemia, dyslipidemia, osteoporosis, kidney stones, and reproductive and psychiatric disorders. Now, some of these are fairly typical that you see with type 2 diabetes, others less so. But when you have a spectrum, thinking about hypercortisolism may actually help us make that diagnosis earlier. So this is one of those overwhelming graphics to let you know there's a lot going on. And I'll deal with these individually, but you can see that there's a lot of systems involved. So let's talk about them individually. If we look at the cardiovascular manifestations, typically we might see these anyway in patients with type 2 diabetes. But when you have hypertension, dyslipidemia, atherosclerosis, thromboembolic disease, myocardial infarction, stroke. Now, once again, these are not uncommon to be seen in patients with diabetes. But when you have, in fact, the role of cortisol, you can see how that might be a linking etiology for that. So that's cardiovascular. Let's look at the musculoskeletal clinical manifestations, which we think of less frequently as part of typical diabetes. Osteoporosis, increased fracture risk, myopathy and muscle weakness, skin atrophy, bruising, and purple striae. So these now recommend different metabolic conditions that might in fact accompany hypercortisolism. If we look at the typical metabolic clinical manifestations, obesity, insulin resistance, which is part of the reason why the diabetes is more difficult to control, beta cell failure, glucose intolerance, diabetes, non-alcoholic steatohepatitis, NASH, or kidney stones. These things represent problems with glucose and lipid homeostasis, as well as inflammation. If we look at reproductive clinical manifestations, often we don't think of this, but if you think in terms of disturbances in the menstrual cycle, polycystic ovary syndrome, PCOS, hypogonadism, decreased libido, as well as male and female infertility, this represents, in fact, parts of the problem that we see with reproductive system failures. And if we look now at the immune system manifestations, and certainly changes in immunity are significant problems with any patient with diabetes, but particularly with hypercortisolism. We see immunosuppression, dysregulation of the inflammatory system responses, infection, and sepsis. All of these result is a result of the regulation of inflammatory responses in terms of cytokine production, as well as immune cell maturation and proliferation, as well as apoptosis. A lot going on, and a lot that can affect the individual. And lastly, if we look at psychiatric nervous system clinical manifestations, impaired cognition, insomnia, depression, anxiety, emotional ability, personality changes, and structural brain changes. All of these, in fact, can be manifestation of hypercortisolism, and often may not be uncovered unless one sort of looks at the problem. People might think, oh, that's just diabetic distress, but it actually may be a result of hypercortisolism. So if we talk about the problem with that, obviously with all of these occurrences occurring physiologically, then making a diagnosis sometimes can be quite confusing. The problem is that the diagnosis is often delayed by up to a decade. And the result of that can be that there's prolonged exposure to elevated cortisol, so you get increased risk of these cardiometabolic issues. And mortality is increased dramatically, 2 to 4 times higher than the general population in patients that aren't treated for their hypercortisolism. And that underscores really the need for our awareness to be heightened and then intervening in a timely manner, particularly in primary care, where we're typically seeing these patients and have the opportunity to recognize some of these dysregulation problems. Now, in terms of cardiovascular risk, we recognize that diabetes and heart disease are very closely linked. And if we have a patient with hypercortisolism, they're at much more increased cardiometabolic morbidities, as well as mortality across the whole spectrum. And even patients that might have less clinically apparent disease, they may lack some of those overt symptoms and features we talked about, but they certainly have increased comorbidities and mortality of a cardiometabolic nature. So by making an early diagnosis, detecting these patients early, we can actually lower their cardiovascular risk and lower disease burden. And the earlier the intervention, the better it is. So how do we screen for this? Well, it used to be fairly complicated, and there are some more complicated ways. We'll talk about perhaps the most effective screen and then some of the other screening tools that we use. So we recognize now that there's certain populations that have higher rates of hypercortisolism. And certainly, while the incidence is generally low, the recent data we see suggests that much more prevalence in those with certain risk factors. So they need to occur so screening needs to occur in patients who have these multiple risk factors. We talked a little bit about it in our case study, but thinking about it will actually raise our awareness. So the pretest probability of hypercortisolism is increased if we screen if they have these risk factors, and so it has a better positive predictive value for that screen. Now, if the pretest probability for hypercortisolism is high, then it's recommended that you do further evaluation even if the person had normal results, because you can have false negatives that might, if you're seeing clinically this patient may actually have it, it may be worth going to more extensive testing. So if we have an enriched population, we're going to get better results. And the 2008 Endocrine Society Clinical Practice Guidelines said screening should include, and not limited to, but in patients with unusual features for their age, such as we talked about, osteoporosis and fragility fractures, type 2 diabetes, or hypertension in younger individuals. And young is a relative term. It's anybody. Anyway, so young people, the patients with multiple and unexplained progressive features like worsening type 2 diabetes outside of the normal progression or unexplained recent weight gain. And also all patients that have adrenal mass, particularly when we find those incidentalomas, those patients need to be investigated. So there was an observational study using prospective hypercortisolism registry and identified a prevalence of up to 50% using those screening criteria. That's a very significant. These are patients we may not have seen. You agree with that, Ashlyn?
Yeah, I think that this really underscores that we're no longer really looking at that 1 in a million or 8 in a million, situation where we're really understanding how much this really is present. If we're using that, we're not screening everybody. We're using specific criteria to look for those individuals who have some features that we're concerned about, and then really seeing this true incidence that's really reshaping how we think about this disease, very much so.
And I think obviously in the practice, you'll see, you may be seeing those patients that have already been pre-screened. And once again, it's incumbent upon us in primary care to identify the potential for these patients and then work with the team. We'll talk about that. That's your job. So let's talk about the prevalence data that we talked about. And this is really a catalyst study. And I love the way they develop the acronyms for these studies. It's a huge sentence here. Catalyst stands for hypercortisolism in patients with difficult to control type 2 diabetes, despite receiving standard care therapies, prevalence and treatment with Korlym, mifepristone. So you can see how they get catalyst out of that. I think it could have been a much longer sentence, but at least they found the letters they need to do. Be that as it may. This is a 2-part phase 4 study conducted in 36 sites in the United States, and they screened over 1,000 patients. The first part aimed to provide a robust estimate of the prevalence of hypercortisolism among patients with difficult control type 2 diabetes. And they really weren't sure what the data was going to show. And I think you'll see in a moment that it's quite dramatic. And what they're looking for was endogenous hypercortisolism as a potential underlying driver of type 2 diabetes. Now, the data from the part 2, which is the treatment phase, is expected in later this year. So the part 1 prevalent phase, they were patients that had difficult to control type 2 diabetes, and they gave them the 1 milligram overnight dexamethasone suppression test, and then they identified hypercortisolism in the post-DST cortisol level of greater than 1.8 microgram per deciliter with a dexamethasone level of greater than or equal to 140 nanogram per deciliter. And then there's further evaluation. They did labs, they did an ACTH, they did DHEAS and cortisol, as well as an adrenal CT scan. So it was a comprehensive way of identifying and evaluating and confirming these patients. So in terms of defining the patients, it is a well-defined population with difficult to control type 2 diabetes that had a high test probability of hypercortisolism. The key inclusion criteria were the patients were 18 to 80, A1C was 7.5 to 11.5, and they're taking 3 or more anti-hyperglycemic drugs. They're taking insulin and any other anti-hyperglycemic drugs, so either one or the other. They're taking 2 or more anti-hyperglycemic drugs and a presence of a 1 or more micro or macrovascular complications, or taking 2 or more anti-hyperglycemic and 2 or more antihypertensive drugs. Now, frankly, this covers a lot of patients that we see in our practice, fortunately or unfortunately, but it tells you that there's a big cohort that may actually have this problem. So the results of the Catalyst study are really very instructive for many of the patients that we see that are somewhat difficult to control. And what they found was that the 253 of the 1,055 patients that screened had hypercortisolism. That represents a very significant number. In fact, it led to the conclusion that 24% of patients with difficult to control type 2 diabetes in the United States have hypercortisolism, much higher than we even suspected. And once again, in primary care practice with patients that are under good control, this represents a huge number of patients for which we should be screening. Now, this number, this 24%, this nearly a quarter of all patients, is really something that needs to grab our attention, which is why we're highlighting it here. All right, so they did the adrenal CT in those patients that were screened, and they found out that 66% of those patients didn't have any imaging abnormality, which is interesting because, once again, it deflects the fact that this is not necessarily a tumor that's causing this. They did see 23% of patients did have a unilateral adrenal adenoma, and that patients potentially could be surgical candidates. But you can see here, only 4% had bilateral adrenal adenomas. There was a adrenal enlargement in 3.4%, and another 3.4% had some other adrenal abnormality. So based upon this, once again, the most number of patients didn't have any screening problem, and really reflects the fact that there's something else going on in terms of endogenous cortisol excretion. So there are a number of strengths and limitations with this study. It's important to know that one of the major strengths is it is a very large, and really the first of its type, rigorous study identifying where the percentage of patients that might have hypercortisolism in the difficult to control population. First of its kind, recruited patients with poor diabetes control despite the fact they were on the best therapies. And they exclude those patients who may have false positive hypercortisolism testing, and also they create a very diverse population in a lot of different clinical practice settings. Now, the limitations are that it may not apply to all patients with diabetes, but I think is very instructive, and it recruited a highly selected the fairly common phenotype of patient diabetes. The imaging studies were community standard. That is, they were done in the community, not done at a regional center. So they may, these abdominal CTs weren't really just focusing on the adrenal. They were focusing just on abdominal CTs. And the treatment of hypercortisolism in this population isn't yet clear. We'll have to look at the results of the Part 2 Catalyst study once again later this year. Well, what does it tell us? Well, it tells us which patients we might want to screen. And if we look at this, the population we can talk about is the patients that are poorly controlled. And that may be up to a quarter or 24% of patients. And examples of the presentation might be they're difficult to control type 2 diabetes, they have an A1C over 7.5, despite the fact that there are multiple effective anti-hyperglycemic medications. We might also look at patients with type 2 diabetes that have poor glucose control despite being on insulin and other comorbidities including obesity, hypertension, hyperlipidemia, cardiovascular disease, and PCOS, common co-presentations of comorbidities. Patients that have diabetes but on high doses of insulin, despite the fact, especially even if they're on prandial insulin, and also patients with type 2 diabetes that had onset before 40 years of age. Also, patients with both diabetes and hypertension that need more than two or more drugs to control their blood pressure. Patients with both diabetes and high blood pressure requiring insulin to control blood sugar, and patients with type 2 diabetes, microvascular or macrovascular complications. So this is a broad spectrum of presentations. Now, similarly, if we look now at patients who might have other clinical presentations, particularly patients that might have the adrenal incidentaloma, and that's maybe those patients have up to half of them will have hypercortisolism, and they present with unsuspected tumors, once again, almost usually just sort of found incidentally. Or patients with osteoporosis, fragility factors, and those fractures, those patients up to 10.8% might have hypercortisolism, and that's premenopausal women with fragility fractures, eugonodal men with fragility fractures, patients with very low or rapidly declining bone density that isn't responding to typical osteoporosis treatment, or patients with a history of vertebral fracture, especially obese patients with vertebral fracture. And then patients with hypertension, this may be up to 8% of those patients having hypercortisolism. We see that hypertension and diabetes often basically coexist, but in patients that are treatment resistant, there may be on 3 or more antihypertensive drugs, including a diuretic, or with hypertension onset before 30 years of age. That should raise a red flag. How do we screen? Well, there are 3 tests that are commonly used to screen for hypercortisolism. The 1 milligram overnight dexamethasone suppression test is the gold standard. It's the one that's easiest to do. It's the most sensitive first-line test, up to 95% sensitivity. The other tests are late night salivary cortisol or the 24-hour urine-free cortisol test. Now, I don't like 24-hour urine tests anyway for a number of reasons. We used to use that to screen for creatinine clearance. Patients would be dropping urine on the exam rooms or wherever they brought it in, or they'd have either these big jugs or small jugs because they didn't recruit. Anyway, be that, we'll talk about each of these tests. The 24-hour UFC and LNSC, they're less sensitive in patients with less prominent symptoms, and sometimes you have abnormally high results with these tests that strongly indicate hypercortisolism. But when you interpret these tests, you need to account for the clinical index of suspicion as well as the patient's history and comorbidities. This will give you an idea of really how accurate this test is going to be. All right, so let's look at the most commonly used test. That's the overnight dexamethasone suppression test. Now, it's easy to perform. Basically, it's a 1 milligram oral dose of dexamethasone at 11 p.m., and then you take a blood sample at 8 a.m., about 9 hours after the dose, looking at serum cortisol and dexamethasone levels. If the test is less than 1.8 microgram serum cortisol with greater than 140 milligram per deciliter dexamethasone level, hypercortisolism isn't likely. However, if the result is greater than or equal to 1.8 microgram serum cortisol with greater than 140 milligram per deciliter dexamethasone level, this is a patient that really is suggestive that they have hypercortisolism. Once again, 95% sensitivity for that, and that may be where you want to consult an endocrinologist. Now, there is some considerations in testing. Certainly, there is the possibility of false positives. If the patient is taking estrogen-containing medications, or if they're pregnant, there may be also some genetic causes of rapid dexamethasone metabolism. There may also be dexamethasone malabsorption failure to take the dexamethasone. There may also be undisclosed use of exogenous glucocorticoids. There could be secondary hypercortisolism due to non-adrenal disease or chronic renal disease. So there are things to consider. The potential factors for a false negative, however, if the patient has chronic renal disease, chronic liver disease, they're taking concomitant medications that inhibit the cytochrome P450-3A4 that lead to very high dexamethasone levels, or cyclic hypercortisolism. So a number of considerations. However, once again, it still has a 95% sensitivity. Well, let's look at the other tests that I'm not so crazy about, but the 24-hour urine-free cortisol. You need to collect all the urine for 24 hours. And we're talking all of the urine. And there may be some intra-patient variability, so you might even need to get more than 2 collections. Patients are going to hate you for that. But in a sense, when looking at the results, you want to look at the reference range, and hypercortisolism cannot be dismissed if there is a high index of suspicion. So it's helpful, but it may not be able to rule it out. And if it's above the reference range, once again, working with your endocrinology colleagues can help you there. There are some considerations, once again. It may be insensitive because of free cortisol does not become detectable in the urine until the serum cortisol levels are high enough to saturate serum cortisol binding globulin. It also is often normal in cases less clinically apparent hypercortisolism, typical of primary adrenal disease. So the potential factors for false positive are high level of fluid intake and secondary hypercortisolism due to non-adrenal disease. The potential factors for false negative are an incomplete urine collection, more common than you would think, or an eGFR less than 60, or cyclic hypercortisolism. Let's look at the last test, the late-night salivary cortisol. This is you need to collect a sample at bedtime, you collect the saliva, and you might need to conduct the test at least 2 or 3 times. Interpretation results is if it's within reference range, the hypercortisolism cannot be dismissed if you still have a high index of suspicion. And if it's above the reference range, once again, working with your endocrinology colleagues can be very helpful. Now, in terms of consideration of this test, these levels are often normal in patients that have less clinically apparent hypercortisolism, and that may be fairly typical of primary adrenal disease. It is useful, though, to detect early signs of recurrent Cushing syndrome. Now, the potential factors for false positive are if there's any blood contamination of the sample, and that can occur with any mouth trauma, including toothbrushing, flossing, toothpicks, etc. If the patient is a smoker or they use chewing tobacco, if they eat licorice, believe it or not, licorice, and licorice is around a lot, use of a steroid inhaler or steroid eye drops or even steroid lip balm may give you abnormal false positive. The use of having an abnormal sleep-wake cycle, that is in terms of night shift workers or sleep-wake cycle disorder, or hypercortisolism due to a non-adrenal disease. Now, the potential factors for a false negative are, once again, in any situation, you have an insufficient specimen volume, or the specimen wasn't corrected incorrectly, or if the specimen hasn't been stored and handled appropriately. So, once again, that makes the dexamethasone suppression test the easiest and gold standard. So, in terms of summary of the screening techniques, once again, we look for the appropriate patients, and that is where they have signs and symptoms that suggest hypercortisolism. High pretest probability of hypercortisolism. Once again, in that situation, you're more likely to get a positive if the patient has the clinical suggestion. We want to use a sensitive screening test. Once again, the 1 milligram overnight dexamethasone suppression test. This is an easy test to do in primary care. And once again, it's going to be the highest yield. And then in terms of interpreting the test, you do it in the context of the patient's medical history and presentation and try to avoid false positives and negatives. So let's look at a patient case scenario, always very helpful. So we'll go back to our 52-year-old man with type 2 diabetes, hypertension, obesity, and hypothyroidism, and he comes to primary care clinic for a routine visit. And during the visit, the primary care clinician notes that type 2 diabetes is becoming increasingly difficult to control due to rising blood glucose despite appropriate treatment escalation. So let me ask you, Ashlyn, what do you think the likelihood of this patient having hypercortisolism based on those comorbidities and his clinical presentation?
I think that this patient sounds a lot like that inclusion criteria that we were talking about. And while we don't have a specific medication list or what his A1C is, think back to what we were talking about for the inclusion criteria for those patients who were screened. An A1C over 7.5% was highly predictive. So that represents so many of our patients. So I would venture to believe that he probably has an A1C at least somewhere in there or even higher if we're seeing that increasingly difficult to control disease. And then we talked about type 2 diabetes plus comorbidities. Those are going to raise our suspicion. So I think he's a really good candidate to get screened, especially I would consider him relatively young as well to be dealing with such an increasingly difficult disease. And definitely that 1 milligram dexamethasone suppression test, you said it great. It's so easy to do. It's very easy to have, I would encourage clinicians to have a template for how to put that in your note. In our institution, we have order sets, so it's very easy to have those specific tests involved, and then you can easily put those instructions together, paper copy to go home or put it through the portal. But I think, it's fairly simple versus 24-hour urine collection. It's really hard to get buy-in for those, or the sleep disruption for the overnight testing. But really take a pill in the evening, come in the morning for some labs. That's pretty straightforward. And I love that you talked about including that dexamethasone level. That's really important because sometimes people forget to take their dexamethasone or they're a hypermetabolizer. And if that dexamethasone isn't high enough, then we're not going to see the suppression that we expect. And that would lead to a false positive.
Living in the Carolinas, I've been practicing in the Carolinas for 5 years now. I was practicing in California before that, and I didn't know that you could fry a salad till I came to the Carolinas. So we have a very unhealthy population, and frankly, in many patients, we consider an A1C of 7.5 being tight control. Not that it's ideal, but once again, there are a lot of patients here that we might think about screening. But I think when you see the other comorbidities, this really raises your awareness that something else might be going on. Well, let me talk about the referral to endocrinology, because we talked about some of these abnormal tests, and certainly that may be an appropriate time for either confirmation of diagnosis and particularly for potential management of hypercortisolism. So there are a number of things we need to do to successfully refer a patient, and part of what I say when I work with residents is we need to tell the endocrinologist what our expectations are of the referral. Just sending the patient there, the endocrinologist may not be aware that we're thinking about hypercortisolism, may just be asking to get better control of their diabetes. So we really need to communicate effectively. And so there's several components of that effective referral. Certainly talking about the patient's relative clinical findings and their medical history is important, but also our key reasons for suspecting hypercortisolism and key factors that might include some of the things like the fractures or that they are an adherent patient, they still aren't getting control, or some of the other factors we talked about, particularly some of the cardiovascular complications. And then describe the testing that's been done and the results of the initial screening test. And it may be that just doing the overnight dexamethasone suppression test may be enough. Doing the other tests may be something that the endocrinologist might want to do. They may have more familiarity with that. But I think at least doing the 1 milligram DST, overnight DST, can be very important. So if we look at a flow chart for this referral, certainly I think having the high index of suspicion is important. That might trigger us to screen for these patients, looking at the medications and talking about the medications and the physical exam, and once again the comorbidities, as well as listing the lab results, talking about the results we got with the 1 milligram DST, and if the test suggests hypercortisolism, proceed then with that referral to endocrinology, and then include all the necessary information for a successful referral, including why we're referring the patient and what our expectations are. So back to our patient. We talked about that. We screened them for hypercortisolism with the 1 milligram overnight DST, and the results are consistent with hypercortisolism. The patient needs to be referred for further evaluation and management. So what do you think needs to be communicated to you in your practice to ensure a successful referral?
This is such a great point because there has been such a legacy of this misunderstanding of hypercortisolism in the past. So in a very busy endocrine practice, it may not be realistic to take in folks who just are sent over, it says concern for hypercortisolism, and that's it. That may not be a good candidate because that further pushes out those wait times and may increase anxiety in our patient if we don't really have that good robust reason for sending them over. So in this situation, I would include the specific factors in the history, like the comorbidities, so type 2 diabetes, hypertension, and obesity, and then any other applicable comorbidities if those are present. And then the fact that the type 2 diabetes is becoming more difficult to control. You could even include on at least 3 medications or on insulin, whatever other factors are relevant. And then putting that information in there that the 1 milligram DST was, let's say, 2.5 with appropriate dexamethasone level. That's a ding, ding, ding. I need to get that patient in. That is an appropriate referral. We're not going to increase unnecessary anxiety, unnecessary wait times, but that is good information and can be summed up in a relatively concise a statement to really be clear to the endocrine colleagues why this patient needs to be seen. So history, those comorbidities, that it's getting worse, and an applicable A1C or blood pressure if need be, that 1 milligram DST is elevated, and the dexamethasone is an appropriate level.
Excellent, thank you. Well, let's talk about your role and the multidisciplinary healthcare team.
Excellent. Yes, this is, as we've talked about, is a complex disease with many different types of medications that are manifestations that may happen. So we're not just dealing with one clinician, one potential treatment option. We're dealing with a very multifactorial disease. So first of all, the majority of these patients are going to be found at the primary care level because many of these conditions are treated by the primary care colleagues. Diabetes and hypertension are often treated at the primary care level. They don't often make it to endocrinology. However, in these situations where we find hypercortisolism, we may be dealing with many manifestations. So we'll talk a little bit in the next couple of slides about who may be considered on this team. But we certainly are dealing with, first and foremost, that primary care team. So it could be medical assistants. Nurses are incredible in terms of education and follow-up and helping with coordination of care. Of course, our PAs and NPs, our physicians, could be dealing with some folks who need social work or extra support, mental health clinicians, either because of some of those mental health manifestations that we talked about, or perhaps just the stress of this disease itself and all that may be associated with it. And then certainly referral to appropriate specialists. So first, we need that referral to your endocrine colleagues. So the endocrinologist, the endocrine PAs or NPs to start with, and then it may proceed from there. So again, we talked about how the primary care clinician may be that first, or typically is that first line who identifies those patients who are higher risk for hypercortisolism and appropriately screening them. and then getting that referral in appropriately, that clear communication about why this patient needs to be seen, what those concerns are, and really starting with an endocrinologist. However, it may be that after then we need many other types of referrals. So we could be sending for additional imaging, so seeing our radiology colleagues, could be treated with nuclear medicine or nuclear treatment. Surgery could be general surgery if we're dealing with a tumor that's not central, or neurosurgery if we're dealing with Cushing's disease. So many different healthcare colleagues that may be involved. And really what's important is that we have a clear communication and a clear structure of what that treatment plan is and that follow-up plan is. So this is for our visual learners. This is a good depiction of kind of what we just talked about. So we could be dealing with medical management, we could be dealing with radiation treatment, we could be dealing with surgical treatment, and of course, very importantly, that follow-up care. But at the center of that is those check-ins with each other on updates on treatment, updates on disease process, and that communication. And I would even go so far as to say at the very core of that center circle is the patient itself. So checking in with your patient, making sure we're clear about where we are in the process, what the next steps would be, and any follow-up. So depending on how the treatment plan is, we may be dealing with, in the terms of medical management, our pharmacy colleagues can be quite helpful. In our institution, we have clinical pharmacists who have regular dialogue with the endocrine team to talk about medication safety and potential interactions, and of course, any other considerations from a medication standpoint. And then nurses are incredible, again, with that education, follow up, looking for any potential side effects that may happen, and then how their response is to treatment. The nursing team can be incredibly helpful. If we're moving to radiation or surgical treatment, those are often done in the hospital. Certainly surgery is, and so our hospital team is key there. We may be dealing with your anesthesiology team, again, nursing team, nutrition, particularly if we've got some of those manifestations that we've talked about, those metabolic manifestations. Again, social workers, there's a lot that's going on in this situation, so making sure that our patient has the appropriate support. Physical rehabilitation. So we talked about some of those musculoskeletal effects, that muscle wasting that they may be experiencing. So we could be dealing with some PT that's needed. And then, of course, mental health specialists to either deal with the stress of the disease itself and the treatment, or if any psychiatric medical conditions have developed as a result of hypercortisolism. And then follow-up is so incredibly important. Following up with the primary care team, making sure that we're following up with the endocrinologists and the surgeons to be very clear about what next steps are. So as you can imagine, if somebody has hypercortisolism and their medications have been intensifying and intensifying, we're adding more and more and more, and now we're treating the hypercortisolism, we very often see weight decreases. We need de-escalation in therapy to avoid hypoglycemia and hypotension and over-medication. So there is definitely quite a bit of follow-up that's needed after this, including being clear about who is going to do the periodic assessment for looking for recurrent or persistent hypercortisolism. We have a really great toolkit with all of this wonderful information that we've talked about today. This paradigm changing information. We have the slide deck. We have resources. We have access to the recording that you can share with your colleagues or reference at a later date on such an important topic. So as a summary, and some of those key takeaways that we want to put in our pocket for Monday morning when we go see our patients, that hypercortisolism is no longer this 8 in a million disease. It's very often missed. We can see a delay in diagnosis, like we talked about, of over a decade, and that prolonged exposure to hypercortisolism really has significant implications on metabolic disease and those comorbidities, as well as increased mortality. And And what we have with this new and emerging information suggests that the prevalence is much higher than we previously thought. And it's no longer just looking for those overt cases. Of course, don't miss those overt cases, but this may be just a very heterogeneous exposure presentation, a heterogeneous disease that may have manifestations in metabolic disease. We may be talking about reproductive issues. We may be talking about musculoskeletal issues, psychiatric conditions, or a mixture of any of the above. And there is a continuum. We may have some folks with very subtle disease, and we may have some folks with much more overt disease. So understanding, like many diseases, that hypercortisolism is on a spectrum. And finally, what can we do about it? So first step is understanding the true prevalence and having that index of suspicion, but then taking that next step. So that pre-test selection is so important, and then using the appropriate sensitive screening test, and then interpreting those tests in the context of the patient that's sitting in front of you. And in coordination of that successful referral to endocrinology, so putting those key findings of that key history in there, the reason that you're concerned for hypercortisolism, and then that screening test result, including that dexamethasone level, and then following up, making sure we have that good team approach. Healthcare is definitely team-based, and so important that our colleagues are clear about expectations, clear in their communication to ensure the success of the treatment of these patients.
I think we've tried to explain how it might be missed because so frequent. I think the biggest challenge might be just prescribing and actually saying hypercortisolism. But once you manage that, I think the issue is it isn't difficult if we have an index of suspicion. I think we've both talked about that, and the very easily available dexamethasone suppression test. But in your experience, are you seeing this being missed by your endocrinology colleagues?
I think that's an excellent question. And actually, one of the points that I was going to make up is we've talked a lot about how the primary care team needs to have this on their radar. But I would definitely say that the endocrine colleagues, we have some of these patients already in our practice that we're treating them for very difficult to control medical conditions, that we're seeing somebody who's on very high doses of insulin, maybe even on concentrated insulin, or they're very young, or we're seeing osteoporosis or fragility fractures that we would be surprised to see, and really reframing what endocrinologists think, that we don't need to wait for that referral from the primary care team to recognize this, that we need to look at our own patients and see if some of those may be eligible. And this is something that we do for other diseases all the time. We get a referral for osteoporosis and we have a screening protocol to look for some of those underlying conditions. So this is very much within the scope of what endocrine colleagues do, but it is very often missed. And part of that is because this is a paradigm shift. We used to think that this was such a rare disease. I know for myself in particular, in the past, I would get people who would self-refer for hypercortisolism just because of a Google search, or I'd get a referral that just said, type 2 diabetes and obesity, concern for hypercortisolism, and that was it. And those were not really those, ding, ding, ding referrals. And I've seen a definite shift now in the perspective of what we really could be missing. And there has definitely been an increase in the diagnosis. But I think that we have a long way to go still before we're truly capturing these individuals. And I think that this is important for primary care and endocrine colleagues to be considering, because we have so long had the wrong impression and we've been missing these folks.
And part of the problem from a primary care perspective is if we make a referral, we're thinking hypercortisolism, and we haven't adequately expressed our concern in the referral, and the endocrinologist doesn't really think of it, then they send back the patient, say, well, no evidence of it, or we don't think that's right. That does a number of things. First of all, it ruins the credibility with the patient, but also with us. We think, oh, I must be wrong. And so we're less likely to screen. So I think, once again, it's really believing that this is way more common than we used to think, and then doing the appropriate communication in that referral so that the patient is actually getting the appropriate management at the time, or at least the appropriate evaluation at the time. Because if there's a interruption of that clear communication, the patient's going to be lost in that middle. And so, we can have a role to educate our endocrinology colleagues in terms of, once again, I think that frequency issue from the Keller study is mind-blowing, really. I think that 24% in those screened patients that have those indications really should change our viewpoint. And once again, we used to blame the patient. You're just not taking medication or eating too much. But thinking physiologically might help us and the patient in that process. So I've really enjoyed hearing your perspective, Ashlyn. I think, once again, hopefully this has been very valuable to our colleagues as they think about these patients that typically have been very challenging, but now I think we can see that they can be quite manageable. So I'm going to leave it to you to talk about how people might get their credit.
Excellent. Thank you, Dr. Brunton. And yes, and in addition to kind of this paradigm shifting conversation and hopefully some really great pearls to take to right into practice to help with some of that shift, you also, of course, want to know about your CE and CME information. So to get your certificate, please complete the evaluation survey. You can use the QR code that's available or the link that is posted here to get your survey. And please remember to fill out the information for the translation to practice credit. So you can really put to credit the changes that we know that diligent clinicians are going to put into place, and we get credit for that.
So thank you, everybody, for your attention. It's been fun working with you again, Ashlyn.
Likewise.
And hopefully this will make a difference with our patients.